Well, I think that there's a lot of different things to consider. Um, Mainly, I think what the goals of the family are and what they want to get out of the therapeutic process, whether it is primarily unilateral skills or bilateral skills, but also from a clinical standpoint, it might be important to think about where the child's at in the developmental process. So some children with unilateral cerebral palsy um, really come into the process at this age and they barely recognize that their paretic side of the body even exists. So if a child is not even pulling that arm and hand into any activities, then a constraint might help, uh, encourage the child to have more of a focus on that side of the body, the paretic side of the body. But if a child is pulling the arm and hand into daily skills and needs more kind of just refinement in bilateral activities, then I would say that what the study shows is that bilateral intensive therapies can be just as effective. Well, you're right. It is. I mean, so we did 60 hours of therapy across 4 weeks, and that is very intensive. But I think that it's important to remember that the therapeutic process is meant to be fun and supportive, and it's meant to be success oriented. So, in that capacity, I think that the advantage that intensive therapies have over more traditional kind of distributed practice models of therapy is it provides a learning opportunity where parents and even the children themselves often are able to recognize changes. And so that is supportive in the process. And so while parents and report that it is hard, they report that the success that they see makes the episode of therapy rewarding, and that can be less exhausting in some ways in comparison to traditional models where you go for an hour a week and you go for week after week, and sometimes you don't see changes or you can't see the changes as quickly. And so the fact that parents see changes and helping parents see those changes and even the children themselves so that they have a sense of accomplishment, I think is the biggest support we can provide. And that can be provided not only by the therapist providing the services, but sometimes we've had grandparents, for example, notice changes, so pointing those out, or a pediatrician that maybe sees a child during the therapeutic process, if they see something that has positively changed, then helping parents identify those and recognize those changes can be a supportive for the whole process. Yeah, so that's kind of the hardest thing to to explain with our study results because, of course, we didn't go into this with any expectations of that as a finding. We really went into trying to document the use of the non-paretic arm and hand, that there wasn't any harm done by the constraint. Um, and so I don't know that I can fully, I can't confidently say what the study findings mean. What I can, other than there wasn't any documented harm, I think what the study suggests, though, is that maybe we hit a time in development. We worked with children between 6 and 24 months of age. So maybe we had a time in development when there's kind of a natural process, neurologically and behaviorally, where the control of the two arms is naturally differentiating. And so when children are trying to use them and one is paretic, maybe it's more difficult for that differentiation to occur. And so maybe the full-time constraint provided an opportunity for that differentiation that could allow for or give a push for the development of even the non-paretic arm and hand. But it's one of those things that, I think we're going to have more studies and more to truly understand. Well, of course, the goal is to help provide children, these lifelong abilities. So increase their early abilities with their arm and hand, and really that the entire paretic side of the body that they can build on for the rest of their lives. And I've been doing this and other studies for many years, and I've had the pleasure of watching children who went through some early therapies now grow up, and some of them are all already completely grown. And they do tell us that they think that these early therapies provided them not only skills, but it provided them confidence in their abilities to keep trying even when things were hard. Um, so I think that is, some anecdotal evidence that of types of things that these change. But and I think that we tried this dosage so early in development because, of course, it's a period when there is a lot of known neuroplasticity going on. So hopefully you're laying some pathways that will be lifelong available for the children. Um, but I think this is another area where we could benefit from more longitudinal studies and truly understanding the long-term impact. And CIMT and bimanual therapies have been around a while now, so I would love to see science do some longitudinal investigation about even looking at the health and well-being of adolescents and, like I said, even some adults at this point who went through some of these early therapies. So we assume that we're laying kind of a foundation of neural pathways that children can utilize then throughout their developmental course and throughout their lives. So we excluded children who had botulinum toxin from the trial because, of course, botulinum toxin creates some real physiological changes in the muscles, and so any changes, positive or negative, that you were documented via any type of assessment, you wouldn't know what was causing it, either the intensive therapy or the botulinum toxin. But there have been studies in older children, not in this age group, but in older children combining intensive therapies with botulinum toxin, and pairing the two together has been shown to be productive and help children benefit from both treatment, from actually the benefit particularly from the botulinum toxin compared with intensive therapies. So I think that it is anytime you do something like botulinum toxin, it's a good idea to compare it with, or to not compare it, but to pair it with intensive therapy processes. So I would encourage that clinically if that's going to occur. But study-wise, it just was difficult to include those children because you couldn't understand your results as well. Uh, but I think it's also it's pretty unusual to use botulinum toxin in children under 24 months of age. So. No, I think the study gives parents some choices and to things to think about, as well as clinicians and things to think about. And I hope overall that it encouraged kind of a conversation between clinicians about what the goals of therapy are, and parents, and talk with them so that they now think about how both therapies might be used, because I don't think it's an either or. I think both of these types of therapies, CIMT and bimanual approaches, might be useful at different points in the child's development, again, depending on what the goals are at that current moment.